currently works as a physiotherapist in the Brain Injury Rehabilitation Service at Burwood Hospital. He's also had experience working in the Burwood Spinal Unit and Pain Management System. And he's going to talk to us today. His presentation is a cohort study of psychosocial factors in relationship to pain in patients with spinal cord injury and stroke in New Zealand.
Great, thank you. So that was actually what I was going to talk about over my first slide. So,
I've saved you 5 minutes.
Saved a minute. Okay. So my supervisors for this were from RTRU, University of Otago in Wellington. So that was Professor Mark Weatherall and Dr. Elliot Bell. So this is a quote from a qualitative study by Hearn et al. In 2015, and I suppose really I think it kind of sums up how difficult pain can be for some people, following a spinal cord injury. So 15 people per million per year suffer a spinal cord injury in New Zealand. And out of the people with a spinal cord injury, between 26 and 96% of people report pain. That's quite a broad range. That was from a systematic review, and it just depends on how they measure it and also what the cutoff points they put in for pain. So, some person said they had 1 or 2 out of 10 pain, then that would be included, more likely to be up towards that 90-odd%. But then some people said, well, it has to be 5 or over. One thing that did come out from it was that about 60% of people rated that as severe, and then the impact that that can have on people's lives can include decreased quality of life, difficulty returning to work, poor subjective well-being, impeded rehabilitation, reduced activity levels, and disrupted sleep. So stroke is estimated to be the second most common cause of death and third most common cause of disability-adjusted life years worldwide. In the subacute population, between 30 and 50% of people may have a pain problem, and then the chronic population has between 20 and 50%, and that's from a number of systematic reviews. And then up to 30% of those people rated as moderate or severe, and it can cause reduced quality of life, increased suicidality, and impeded rehabilitation, all of which I've certainly seen in my clinical practice. So the psychosocial factors that I looked at in particularly were pain coping strategies, and within that, pain coping strategies was pain catastrophization, also pain-related attitudes and beliefs, and also mental health. So pain coping strategies are efforts that people engage in order to decrease either the pain severity or the impact that pain has on their life. Pain catastrophization is defined as the tendency to focus on pain and to negatively evaluate one's ability to deal with it. So pain catastrophizing has been shown to be one of the strongest and most consistent psychosocial factors associated with pain and dysfunction in samples of people with chronic pain as their primary presenting complaint. Looking at populations with spinal cord injury, so many coping strategies have been found to be associated with pain. These studies were mainly cross-sectional, and in chronic populations, pain catastrophization, there has been an association shown between pain outcomes and pain catastrophization in chronic spinal cord injury populations. Then there was one study which looked at a subacute population, and it didn't find that association. And there's been no research that has looked at that in stroke patients. Pain-related attitudes and beliefs will affect a person's understanding of pain, and also pain's meaning with respect to their present or future quality of life. So in populations with spinal cord injury, pain-related attitudes and beliefs can either have a positive effect, so an example would be a belief in control over pain, or they can have a negative effect. So a belief that pain signals damage and that activity should be avoided. So again, this research was in more chronic populations and also cross-sectional in nature, and then no research exists for stroke patients. Mental health, so there's strong associations being shown in the literature between pain, depression, anxiety in populations of spinal cord injury and stroke. That's mainly in chronic populations, again in cross-sectional, and then in a subacute population of spinal cord injury, which is the only one that I could find, there is no association found. So the conclusion from the literature review is that There's evidence of associations, but since most studies were cross-sectional, you can't really tease out those sort of cause and effect. There's very few studies looking at patients early following their diagnosis, and then some of those studies that did, even though there were only 2 small ones, had some different findings to chronic populations. So one thing that I had to take into account is that many factors need to be measured for it to be comprehensive, but then you increase participant burden, and any of the studies with a number of questionnaires certainly had poorer response rates. So in conclusion, from the literature review, is that there was just a need for prospective longitudinal cohort studies in more acute populations and also in populations of stroke patients. So the first research goal was to estimate the strength of associations between patient demographic factors and pain intensity and pain interference. And that was really just searching to see if there was any demographic factors that would be confounders to the associations found. Then the second one was to estimate the strength of associations between psychosocial factors early after the onset of a new neurological problem and pain intensity and pain interference. Then the last aim was looking at the strength of association between those early psychosocial factors and then pain intensity and pain interference at 6 months. So, so the method that I chose was prospective longitudinal cohort study. My inclusion criteria was people need to be over 18, participating in inpatient rehabilitation following a new neurological injury. They couldn't have any history of neurological injury or history of chronic pain. And then they needed to have sufficient cognitive and communication abilities to be able to answer the questionnaires. So the patient population was the brain injury unit here at Burwood, also 2A in the Princess Margaret, which is now the DG ward down here, and then the Burwood Spinal Unit. For pain intensity and pain interference, I used the brief pain inventory. For coping strategies, I used the coping strategies questionnaire. The survey of pain attitudes was used for the pain attitudes and beliefs, and then the 5-item mental health subscale of the SF36 is what I used for the measuring mental health, which was anxiety and depression. And then linear regression analysis and analysis of variance was done through SPSS. So on admission, I managed to get 32 people into the study. Pain prevalence in the spinal cord injury population was over 90%. And then in stroke, it was just over 40%. So that was in line with the other research. Treatment efficacy. So the brief pain inventory actually measures treatment efficacy. Everybody on admission to the study that had pain was getting treatment, and 74% was the mean relief that people reported. For the stroke population, it was about 78%, and then for the spinal cord injury population, that was about 73%, so it was quite good at the start. Then measured the brief pain inventory, the treatment efficacy at 6 months, and what it found is that the mean relief was about 35%. So for stroke patients, that was about 25% relief that they reported, and 37.5% for spinal cord injury patients. So you'd see the difference between that early pain treatment efficacy versus at 6 months, just for this population, was different. So then looking at the study aims, so the pain variables were associated with diagnosis and age. The spinal cord injury patients were younger, and they were more likely to have a higher pain prevalence, so that probably explains that. And then I think I've got a table. Yep. So a greater belief in a medical cure for pain was associated with less pain interference at baseline. A greater belief that pain indicates damage and that activity should be avoided was associated with pain intensity and pain interference at baseline. So that greater belief meant that people were more likely to have an increase in their pain intensity and pain interference. So a greater belief that others should be solicitous in response to his or her pain experience was associated with greater pain interference, and then poor mental health was associated with higher pain interference. So then at 6-month follow-up, so a greater belief in a medical cure for pain was associated with decreased pain intensity and pain interference at 6 months, and poorer baseline mental health was associated with increased pain intensity and pain interference at 6 months. So there's similar pain prevalence in my population as there was to other spinal cord injury and stroke populations. One thing that was found in my study was just that treatment efficacy is that it was quite good at the start, but then 6 months later that pain relief was harder for people to find. So the belief that pain was an indication of physical damage and activity should be avoided. So that was associated with some pain outcomes early on during people's stay, but then not at follow-up. Potentially the sample size was too small, or maybe through rehabilitation they learned that it was okay to move. A belief in a medical cure for pain was found at baseline and at follow-up to have associations with pain outcomes, and just how that fits in around maybe the literature that's there around expectations and outcomes. And then solicitous responses, so the belief that others should be solicitous in response to pain experience was associated with pain interference. There's quite a lot of literature out there that looks at the effects of social supports quite broadly. Social supports are really, really good, and people with social support do better, and they have better outcomes in terms of pain. But really what they were saying is that you need to look at the type of social support that they're getting. So the quality or type of social support is quite important. And then mental health, so at baseline and at the 6-month follow-up, mental health was associated, so poor mental health was associated with worse pain outcomes. That's I suppose a little bit of a sort of a chicken and the egg scenario, like when you're looking at it. So if you're in pain, that is going to affect your mental health. But then, really, from all the literature that I was looking at for my discussion, it says that it's probably a mutually reinforcing relationship. So it's not that solely one affects the other. It's that they both actually, it's a relationship where they I suppose feed off each other just a small bit. So the importance of actually treating both at the same time, kind of quite strongly. And then coping strategies and catastrophization. So I didn't find any at baseline or at 6 months, so any associations between those. And then that finding for catastrophization, for example, was found in another subacute population of people with spinal cord injury. So limitations, of which there are a few. So look, the sample size is kind of the glaringly obvious one. 32 people at baseline and then 19 at follow-up. Did end up missing out on a number of stroke patients, so because of excluding cognitive and communication difficulties, I was expecting to miss out on a couple, but probably what I didn't expect was the amount of chronic pain in an older population, so people with arthritis, peripheral neuropathies, that actually was a large proportion of people that I ended up missing out on. Also, I couldn't measure all potential variables, so not just psychosocial, but physical as well. There's plenty of factors, physical factors that are associated with pain in spinal cord injury and stroke. The other one is just the use of self-report questionnaires. Usually what they say is that it's good to have a self-report questionnaire, but it's good to have a physical test to go along with it. But within the scope of the master's project, that was going to be pretty hard, to be honest. Yeah, so from the literature that I looked at, so this is the second study looking at psychosocial factors in the subacute spinal cord injury population, and the first study in stroke population never defined a subacute one. So any conclusion kind of comes with little asterisks, sort of terms and conditions. It has to be viewed with the study's limitations in mind. But I'll go ahead anyway. Yeah, so some psychosocial factors have been shown to be associated with pain variables in subacute populations with stroke and spinal cord injury, and some of the associations that we're seeing are actually in line with those for chronic populations. However, some associations that have been seen in those chronic populations may not actually be seen in acute populations. And the big example there is pain catastrophization. So in the future, so potential future implications, one of them that I have down there is looking at that more biopsychosocial approach to pain management early on in people's rehabilitation. So in the current study, the treatment efficacy was found to be poor for spinal cord injury and stroke populations, and that's been found in previous qualitative and quantitative studies, with people from those populations actively seeking out alternative treatments to biomedical necessarily, and that would include psychological and exercise, just other sort of coping strategies. And potentially early pain education may help with some of the fear avoidance beliefs. So benefit of looking at biopsychosocial approach in an inpatient rehabilitation population would be that the full interdisciplinary team is present over a 24-hour period. You can do group education sessions with the patient, with their family and their whānau. Positive coping strategies can be reinforced early, as well as challenging unhelpful beliefs around pain, and then early treatment of mental health conditions using pharmacological and non-pharmacological approaches. So just quickly, I'd like to thank the participants in the study. It wouldn't be much of a study without them. Then the staff on BURS 2A, which is now DG, also Burwood Spinal Unit, who helped me with recruiting patients. I had excellent supervisors, Professor Mark Weatherall and Dr. Elliot Bell, and the CDHB and the Neuro Special Interest Group of Physio NZ, who helped me out with some funding. And then I should probably put it in bold and put it in capitals, really, to be quite honest, because working full time and doing a master's, I mean, you don't do it without the social network around you. So just, yeah, family and friends. That's it.